Good afternoon, everybody. Welcome back to Ground Rounds. Today we have Julia Frith talking about chickenpox. I'm going to start sharing my screen. Julia.
All right, great. Let me share mine. All right, is everyone able to see my screen? Hopefully the correct screen.
Can you see the screen?
All right, fantastic. So thank you, Tatiana. Today I am going to talk to you guys about chickenpox for the next 30 minutes or so. So excited for the opportunity to present to you guys today. All right, so funding for this presentation is provided by the Kentucky Department for Public Health, and I have no financial disclosures. Objectives for today are to identify the impact of the varicella vaccination on preventing disease, as well as identifying key infection prevention activities to prevent exposure to varicella. So let's start off with a scenario. So Anytown, USA is a community in the Midwest with an excellent children's hospital. A 7-year-old child presents to the emergency department with fever and an itchy rash. The patient is seen and triaged promptly after arrival, but spends 50 minutes in the waiting room before being roomed. A clinician examines the patient and suspects chickenpox based on the appearance of the rash and concerning history. The child has never received a varicella vaccine. He is a second-grade student at a school where 3 other students have recently been diagnosed with chickenpox. So let's talk about the epidemiology of varicella, commonly known as chickenpox, for a minute. Varicella, or chickenpox rather, is caused by the varicella zoster virus. It is considered to be highly contagious, though admittedly not as contagious as measles. This illness does occur worldwide and is primarily a childhood disease. Transmission of chickenpox is person to person, so contact with the vesicular fluid, inhalation of aerosols from the vesicular fluid of the skin lesions, or infection respiratory tract secretions. Typically speaking, varicella zoster virus enters the host through the respiratory tract and conjunctiva. It replicates at the site of entry in the nasopharynx and in the regional lymph nodes, and primary viremia occurs 4 to 6 days after infection, and the dissemination of the virus to the other organs such as the liver, spleen, and the sensory ganglia. Again, other replication can occur and you end up with infection of the skin. And it can be cultured from mononuclear cells of an infected person from 5 days before to 1 to 2 days after the appearance of the rash. Infection or your infectious time is 1 to 2 days prior to onset of rash until all lesions have formed crusts. The incubation period is 14 to 16 days, but it ranges from 10 to 21 and could be as long as 28 days in some settings, particularly in those who have received post-exposure prophylaxis with varicella-specific immune globulin. So some of the clinical features, so individuals may have a fever 1 to 2 days prior to the rash. However, rash, particularly in children, is often the first sign of disease. An individual who has not received the varicella vaccine, the rash is generalized and curatic and progresses rapidly within 24 hours. It goes from macules, so flat red bumps, to papules, those raised red bumps, to the vesicular lesions before crusting. It usually appears first on the scalp, face, or trunk, and then it spreads to the extremities with the highest concentration of lesions typically on the trunk. These lesions can occur in mucous membranes of the oropharynx or respiratory tract, as well as conjunctiva in other locations. They're about 1 to 4 millimeters in diameter, and typically the vesicles are superficial. However, they can rupture and become purulent before they dry and crust. One thing to note is that successive crops appear over several days. And so that means the lesions may be present in all stages of development at the same time, meaning that patients may have macular lesions in the same area of skin as mature vesicles. And so healthy children usually have upwards of 500 lesions in 2 to 4 successive crops. The clinical course, however, is typically mild in healthy children, but complications do occur, including bacterial infections that are secondary to skin lesions, primarily caused by staph species or streptococcus. Interestingly, these are the most common causes of hospitalization and outpatient medical visits and can ultimately lead to death. Pneumonia following varicella is usually viral, but may be a bacterial pneumonia, and less frequently is CNS manifestation, and on the very rare side is Rye syndrome. Additionally, individuals may later in life develop shingles. So the presentation of chickenpox in vaccinated versus unvaccinated difference individuals may appear to be different. So here are 2 images of individuals that have chickenpox on their trunk. You can see that it is dispersed about their trunk, and those lesions, if you could see closer, are in the different phases of crusting. This is the typical presentation of those individuals that are unvaccinated for chickenpox. Inverse to that, individuals with breakthrough chickenpox, or those individuals that have been vaccinated and end up with chickenpox, might not have as many lesions on their body as those that are unvaccinated, which is depicted in these images here. So the question becomes, why do we vaccinate? So this graph represents cases from 1972 to 1996, and it illustrates the number of cases reported plummeted after the introduction of the chickenpox vaccine in 1995. In the pre-vaccine era, varicella was endemic in the United States, and virtually all persons acquired varicella by adulthood. Therefore, the number of cases occurring annually was estimated to be approximately that of the number of individuals that were born, so about 4 million people per year. And the majority of those cases, about 90%, occurred in young children that were less than the age of 15. The incidence of varicella, as well as varicella-related hospitalization, which we will see on some subsequent graphs, has declined significantly since the implementation of the varicella vaccination program in 1995. And incidence overall declined 97% from the pre-vaccine years. And this was based on data from 4 states that have continuously reported their vaccination or their varicella status. Interestingly, the cases declined in all groups. So this included infants who were not eligible for vaccination and adults who historically have had a lower rate of vaccination overall. And this really indicated that the protection from the varicella vaccine impacts the community as well as those that have been immunized. In 2006, we adopted the 2nd dose of varicella vaccine, and we saw an additional decrease in overall identified cases of varicella disease. So what about hospitalization? So we talked about the cases being relatively mild. However, there are complications that are associated with chickenpox. This graph here shows just overall where we were with the 1-dose recommendation at a rate per 100,000 in the population, and then the again decline in those individuals with the 2-dose recommendation. It also shows the overall decrease in hospitalization. And so really what this shows is that the vaccine is very effective. 82% for 1 dose and 92% for those that received the second. The risk for complications from varicella varies by age, and the complications, while infrequent among children that are healthy, they do occur in individuals older than 15 and individuals that are less than 1 year. Interestingly, in the pre-vaccine era, approximately 10,000 individuals with varicella required hospitalization every year, and those rates were approximately 1 to 2 per case per 1,000 cases among healthy children and 14 per 1,000 cases among adults. When you look at overall mortality rate, again, inlaid over the same graph that was our 1-dose, 2-dose vaccine, you can see that the mortality rate also shifted. The fatality rate for varicella was approximately 1 per 100,000 cases among children ages 1 through 4. And this actually decreased since 1995. And deaths and hospitalization from varicella have declined in the United States 93% and 94% respectively. So this graph here just depicts the percentage of children aged 4 to 17 that ever had varicella. And again, this is after our immunization programs have occurred. So during the first 25 years, the United States chicken vaccination program has prevented an estimated 91 million cases. That is an exorbitant amount of cases of chickenpox. It's prevented 238,000 deaths, hospitalizations, and 2,000 deaths. The program started in 2005. So at that point, prior to that, 4 million cases were identified each year, 10,000 hospitalizations, and 150 deaths. And now we're down to less than 30 deaths per year, and arguably hospitalizations and deaths have been noted to be quite rare. So why do I bring this up? I bring this up because we know that vaccination programs work, particularly as it relates to chickenpox. And we know that we have some great opportunity post-pandemic to get people back onto regular immunization schedules. And so this is a headline from the World Health Organization where we are currently experiencing the largest sustained decline in childhood vaccinations in approximately 30 years, according to the World Health Organization and UNICEF. And so their quote is, "This is a red alert for child health. We are witnessing the largest sustained drop in childhood immunizations in a generation, and the consequences will be measured in lives." The UNICEF executive director states that while a pandemic hangover was expected last year as a result of the COVID-19 disruptions and lockdowns, what we are seeing now is continued decline. COVID-19 is not an excuse, and we need immunizations to catch up for the missing millions, or we will inevitably witness more outbreaks, more sick children, and greater pressure on already strained health systems. So the question becomes, where are we in the state of Kentucky? So the American Academy of Pediatrics Child Vaccination Across America website has a beautiful table for all of the states in the United States and what their vaccination rates are for childhood vaccines. And you'll note here that our varicella vaccine rate for those individuals that have had at least one dose in children that are 24 months of age or greater is at about 89.1%. So that's less than the United States vaccination rate overall, which is at a 91.1% vaccination rate. I'll also draw your attention to the other vaccines that are recommended. MMR, particularly, knowing that it is highly contagious and transmissible, and acknowledging that the MMR and varicella, typically those rates run very close together. So MMR is at an 89.2 with a 9.1 or 91.6 for the United States, and with a goal in the United States, or Healthy People 2030 target of a 90.8. So one of the main things that we look at from a vaccination perspective is what are our school age children and what is our vaccination rate. And so this table here depicts where Kentucky is as it relates to to the national estimate. And this is based off of kindergartners that are school age and are entering into the school system. So in the state of Kentucky, in the 22 to 23 school year, we had approximately 54,000 children that entered into school. And what we know is that from 2019 to 2020, the average state vaccination declined among kindergartners from 95 to approximately 93%. And that decline remained the same for those individuals from 2022 to 2023. Interestingly, the average percentage of children with an exemption that increased from 2.6% during the 21-22 school year to 3% during the 22-23 school year. This is the highest exemption rate ever reported in the United States. The exemption rates increased in 41 states, exceeding 5% in 10. And this is an important percentage because exemptions greater than 5% limit the level of achievable vaccination coverage, increasing the risk of outbreaks of vaccine-preventable diseases. And so overall, 3% of kindergartners had an exemption, though interestingly, only 0.2% of those were medical and 2.8% were non-medical. Non-medical exemptions accounted for greater than 90% of reported exemptions and approximately 100% of the increase in the national exemption rate. And this excluded for those individuals that had provisional enrollment. So were able to enroll and had a grace period. Because we know clusters of under-vaccinated children can lead to outbreaks, obviously it's very important for programs in schools to have vaccination programs and for children to be fully vaccinated prior to entry. Interestingly, we are seeing an increased number of clinically diagnosed chickenpox in Jefferson County children, and at least 2 schools have had multiple cases. I'm looking at Jefferson County overall. About 30,000 JCPS students are not up to date with all recommended vaccine, and some of these students are lacking the varicella vaccine. The CDC in 2023, they actually launched an initiative to address this post-pandemic related decline in immunization called Let's Rise. And it is really to enhance communication, back to school immunization programs, and making sure that coverage is back to the levels of pre-pandemic. And so when you look at the state of Kentucky, while we are at a 1.7 exemption rate, that is still a large percent of the individuals that are in our schools, and we are at an 89.8 percent of those individuals that have received their 2 doses of varicella vaccine, indicating there is a discrepancy between the exemption and the ones that are not up to date. So let's take it back to the scenario that we started with. So our patient that comes in from Anytown, USA, the 7-year-old, we know that this individual presented with symptoms clinically concerning for chickenpox and likely is going to be diagnosed with such. They sat in a waiting room of an emergency department because it's not uncommon for a child to have a fever and to even have a rash. And so sat in the emergency department waiting room for a period of time before they were ultimately diagnosed or seen by a provider in a room. So what do we want to do from an infection prevention perspective? One key element is that we want to be very preemptive in establishing protocols around healthcare worker immunization, prompt isolation of individuals that present with fever and rash, and isolation of those patients or those individuals that have been exposed. And so when we talk about establishing protocols for employees, proactively for immunity, really understanding what is proof of immunity. So according to the American Academy of Pediatrics Red Book, this could include up to date on their immunization, lab evidence of immunity or confirmed disease, diagnosis by a clinician or verification of history, and a history of herpes zoster diagnosed by a clinician. What we want to do with these individuals that come in with concern for or confirmed chickenpox is to promptly isolate them. They should be placed into airborne and contact precautions, and hopefully they don't sit in the waiting room for any period of time. The duration of isolation is until all those lesions are dried and crusted. And remember, that can be over a series of time because not all of the lesions appear at the same time. For those individuals that have been exposed, however, if they have been exposed and are unimmune, they need to be isolated from day 8 until 21 days after exposure to the index patient. And this could be longer depending upon if the patient or that individual had to receive varicella zoster immune globulin or IgIV secondary to their exposure. So what does that exposure process look like? So you have this patient, they come in, what do you need to do? So the first thing you're going to want to look for is to identify those individuals who lack evidence of immunity to varicella. So this includes your healthcare worker, patients, and visitors. You want to see if they can receive the immunization. So the varicella immunization is recommended for people without evidence of immunity, as long as there's no obvious complication, contraindication. So this is for use. The vaccine is recommended for those persons age 12 or older. And this is from days 3 to 5 after the exposure. Interestingly, if they get the vaccine within 3 days of exposure up to 5 days, it can be 70 to 100% effective. The varicella zoster immune globulin could also be administered to appropriate candidates, and this would be up to 10 days after the exposure has occurred. If the vaccine cannot be administered and the varicella zoster immune globulin is not indicated, preemptive oral acyclovir or valcyclovir can be considered for some individuals. As it relates to patients, if they've been exposed and can be discharged, they should be discharged as soon as medically indicated. But if they need to remain in the hospital, those individuals should be isolated from day 8 through 21 or up to 28 after exposure or medication received. So what about our healthcare workers? So healthcare workers who have received 2 doses of vaccine should monitor for symptoms from day 8 to 21. having a protocol or a process in place for how that monitoring looks, who they report that to, and who they notify when symptoms occur is imperative, and having a low threshold for symptoms such as fever, headache, or skin lesions that occur. If the healthcare worker only has received one dose of vaccine, they should receive a second dose and within 3 to 5 days of exposure, as long as at least 4 weeks have elapsed from that first dose of vaccine. And then they would be managed in the same way that those individuals that had the 2-dose vaccine. However, healthcare workers that lack immunity, they should receive the vaccine as soon as possible, but they also need to be restricted from work from day 8 through 21 up to 28 days should they have received the immune globulin. So what are the questions to consider for other exposures? What about patients? What about visitors? What about those individuals that were in the waiting room? The Red Book has a nice table that they have put together about what constitutes a significant exposure, particularly household members that reside in the same household, if they have face-to-face indoor play for greater than 5 minutes, if they are a newborn infant in general. And then it does specify what to do in the setting of the hospital when an individual has varicella around room size, so a 2 to 4 bed room or adjacent wards. But what about locations such as waiting rooms? So one question that that is asked frequently is, does the waiting room need to be closed down? And that's probably not necessary. There are recommendations for shutting down waiting rooms when measles exposures have occurred. But for chickenpox, while it's highly contagious, it's notably not as contagious as measles is, where it is explicitly indicated of what to do in those waiting room settings. But you do need to recognize who are those individuals that were in the waiting room that were potentially exposed. So some facilities say if you were in the waiting room for at least 5 minutes with the index patient, then you're considered exposed. And some locations might say 15 minutes or an hour. What I would encourage is that everyone look and see what is and establish that protocol so that you're not trying to figure out what is an exposure at the time of the exposure occurring. Additionally, you want to identify those individuals that are high risk. So infants that have not yet been immunized and immune compromised individuals, and reach out to the provider to see, do these patients need to be immunized? What do we need to do for these individuals so that they can be treated and promptly isolated? Additionally, there's some question about closing exam rooms. And so you'll note on here, it doesn't explicitly say what to do about exam rooms, particularly those that are not airborne, but some facilities do close those exam rooms down for a period of time. And we'll talk about that in a minute on the next slide. One thing to be sure to do is ensure that the patient wears a mask until they are in an airborne precaution room, as long as they are medically able. So the California Department of Public Health also has a very nice quick sheet. So this is a document that is up to 8 pages that speaks to controlling for and exposures and suspected exposures to chickenpox. You'll notice in this particular exposure quick sheet, they do shut down the exam room for up to an hour in the setting that an individual does come into the emergency department and is diagnosed with chickenpox. I would just encourage that if that is a decision that your facility makes, to be sure that you have a process or protocol to understand how you're going to operationalize that process. So just looping back around, what we know is that varicella cases absolutely decrease when we vaccinate our patients. And we also know that it can be a large impact on our healthcare system in the setting of unimmunized people. We know that we have less immunized individuals now post-pandemic, and therefore we are seeing a rise in vaccine preventable illnesses, specifically in this case, chickenpox. And so I would highly encourage that you look through the protocols that you have in place at your facilities and see what you need to do to ensure that should a patient show up into your emergency department, your outpatient setting, your waiting rooms to visit a family member or friend in a skilled nursing facility or rehab location, what is it that you're going to do? How are you going to manage exposures? And what are you going to do about your healthcare workers? And how are you going to ensure immunity over time? And that is all I've got. Any questions for me?
Alrighty, thank you very much.
Right.
Next week we will have Vanessa Fisk talking about source control. So we will see everybody next week. Thank you.
Thank you. Bye.
Bye.